Well, dear ladies and gentlemen, it's an honor for me to present to you our work on beta-tricalcium phosphate composites, which we developed for socket preservation and for bone regeneration. My name is Kurt Ruffieux. I'm a developer of resorbable implants, and I'm doing this in a company that I founded 10 years ago as a spin-off of the Swiss Federal Institute of Technology. I would like to show you in my first slide a little bit the overview of resorbable implants as they are used today in the market. It all began in the 70s, as you can see on the top left pictures, with synthetic resorbable sutures. They became broadly used, and from then on development went into further applications like into dental membranes as you know them today. In the 1990s we started to develop screws and plates for maxillofacial surgeries, as you can see on the top right in the picture, and these are today a standard, especially in pediatric craniomaxillofacial surgery. Other applications contain sports medicine, where you use suture anchors to refix ruptured tendons and ligaments, screws for knee surgery, screws for meniscus operation. Foot surgery is a coming field with hallux valgus operations, and just lately we developed a resorbable cage for spinal applications. In 1997 I was approached by two doctors, Dr. Suhonen and Dr. Schuck from the University of Zurich, the Faculty of Dentistry, and they confronted me with the problem of alveolar ridge resorption after tooth extraction. They showed me these dramatic effects that extraction of a tooth may have on the alveolar ridge, and asked if I can help to work on a new therapy that they have been inventing. This new therapy consists of looking at what is done in the past, like you extract the tooth, you do nothing, and the alveolar ridge goes away. And for them it was kind of like dentistry in medieval times, and they said this is not a today's method anymore, and we should work in a more preventive way by filling the bone defect after tooth extraction with something that will form bone there. You have the nicer advantage of having a 5-volt defect with a good biological environment that can fill the defect, which should be much better than waiting until you have ridge resorption and then augmenting again using a 1-volt defect situation. So we wanted to turn this idea into a product that should help patients worldwide. The idea, as you can see in this slide, was to make an exact copy of the tooth root in a silicone mass, to fill this negative with a biomaterial that would harden, and then you have this exact copy, as you can see in the picture on the bottom left. This is plugged back into the extraction site just about 5 to 10 minutes after the extraction was performed. So to do that we had to develop a new biomaterial, and I would like to go through this development with you in the next slides. Well, first we had to decide what kind of bone graft material we want to use, and we decided we are going to use synthetic materials. Why? Well, the other materials, I think they all have disadvantages that we want to overcome. Autologous bone is the golden standard, but you have the problem of a harvesting site. Then you have the allogenic bone and the xenogenic bone, which come from other sources as the patient itself, with problems associated with that. So our belief is that we should make or should use synthetic bone grafts, and we should work on them to enhance their properties until they're at least as good as autologous bone. So we started by creating a beta-tricalcium phosphate granule. We made a roundish granule, as you can see in the slide here, which has a porosity of over 50%. We made sure that we really have a phase pure beta tricalcium phosphate, so we know exactly what we are using and implanting. And we made sure that we have an interconnected porosity within the granules, which will allow the fluid exchange throughout the granules. We made sure that these granules are really phase pure, and we used XRD spectra and infrared spectra, as you can see in these slides. So we benchmarked them with other products, and we were able to show that we have a granule which is larger than 99% phase pure. We went into an ISO standard dissolving test. As you can see here, you see the blue bar is the granules we developed, and you can see they passed this test at 100% solubility after 3 hours in this pH 3 citric acid solution, which mimics the activity of the macrophages in the body. So as next, and this is the innovative step that we did, we coated each granule with 10 microns of a polylactic acid. So very, very thin coating that would allow us to stick the granules together. This coating is there for 3 to 4 weeks, and after that it is resorbed completely by the body. This coating has another very interesting benefit. Kind of prevents bacteria from growing into this porous granule. So this was the next step we did. Of course, we needed to check out if this coating has any influence on tissue regeneration, because during degradation of this coating there is a release of lactic acid. What we did is we went into an animal study where we used a rat model and implanted rods of 2 × 3 × 20 millimeters into the dorsal muscle tissue of the back of the rats. And we measured over the period of time the acidity of the blood, and with using a sonde we measured also the value of the pH in the muscle tissue. And as you can see here in this graph, we were not able to measure any difference in pH over a period of 72 weeks. We also inserted these granules, the pure TCP granules, together with coated TCP granules in an animal model. We used sheep and introduced these granules into the humerus and femurs, where we created supercritical size defects. And we checked it out after 2 months, and histologically we were not able to see a difference after that time between the 2 types of granules that we inserted. Now, one important factor is porosity and the morphological structure of this root analog. And with the gluing together of the granules, we're able to make an exact copy that would really fit perfectly into the alveolus. So we have immediate contact to the surrounding bone tissue, and we have a mechanical stability that will reinforce the lamella of the alveolus. And we have interconnected porosity between the granules, as you can see in the next slide. Here on the left you see an SEM picture of this biomaterial, and on the right you see a cross section of that, and you can see the porosity available between the granules, which will allow immediate ingrowth of tissue. We measured this porosity, and we have seen that we do have pores of up to 700 microns, with an average pore size of around 200 microns. So tissue is able to grow into a structure like that. We made sure that this biomaterial is likes blood, and so as you can see, it can really take up blood. So blood can invade the graft, which is optimal for bone regeneration. The degradation of the material takes place in 2 steps. One is that the coating of these granules, as I described before, goes away within 3 to 4 weeks. And you can see here in these 4 pictures that after 2 weeks the graft is still stable, and after 38 days you have just pure phase beta-tricalcium phosphate granules within the defect. And in the second stage, the bone tissue will form around the granules and gradually replace the granules. Beta-TCP is quite a good material in our opinion, because it degrades within a period of about 1 year, giving bone ample time to form within the site. We then went into an animal study where we were using a mini pig model. We were using pigs of age between 3 and 6 years, where we extracted teeth and filled the extraction site by this beta-TCP PLA composite. And you can see here how it was done, and on the bottom left you can see the histologic section after 20 weeks, and here you can see it even more closely. And you can see how bone has already formed within the defect after 20 weeks and kind of bridging the bone graft on top. The next picture, you can see the same situation or the same site after 40 weeks and 60 weeks. After 40 weeks you do still see some residual material in the core of the implantation site, and after 60 weeks you cannot see that anymore. After 60 weeks we went more into details at the site where we placed the graft, and we even went to a transmission electron microscopy analysis, and we found after 60 weeks that there were still some small TCP particles present, but they were all outside the extracellular matrix and grabbed by giant cells. So for our histologian, this was the proof that this TCP really is completely degradable, because these particles within the giant cells, they will be dissolved and transported away within the next coming days. So then we went into a clinical study at the University of Zurich, where we treated 30 patients and implanted into 38 extraction sites. The patients were completely randomly selected, and we had no exclusion criteria for patient. So we had smokers, we had anticoagulated patients, we had patients with diabetes and other medications. We inserted it into 9 front teeth and 29 side teeth. Here you see exemplary one of the cases that were treated, and in this patient, as in other patients, we have used a tooth with 2 roots and used 1 root as a control, as you can see in this picture. Now here you can see the situation after 12 months. The implant that was used was inserted after 6 months. You can see on the right side of the implant where this root replica was placed, you have a very nice bone formation, whereas on the left side you can still see the contours of the alveolus as it was present 12 months before. And this clearly shows that if you treat an extraction socket, you have an advantage for your patient. And of course we measured the width and the height of the alveolar process where we have placed the root replica and of the control sites. Here you see a histologic section that we took after 6 months. All patients got implants after 6 months. On the picture at the bottom you can see the histologic section entirely. On the right side you can see the old bone that was still present. And you can see that the TCP granules, which are white in that pictures, are still present there, but they are surrounded by this light green stained undifferentiated tissue. And on the picture on the top left you can see how this tissue is invaded by osteoids and is being transformed into maturated bone. The picture on the top right, you can even see that some of the osteoids after 6 months even formed within the TCP granules. So after 6 months, these granules are less dense than at the original implantation date, so that they can be invaded by bone tissue already. The summary of this clinical study we conducted in 2003-2004 was as follows. Dr. Schuck, the leader of the study, he said that this product or this therapy is safe and preserves the alveolar bone structures in dimension in the short and mid-range term. He found that the predictability of the result was good and that in all patients where he implanted the titanium implant, immediate primary stability was good. In no cases additional bone augmentation material was needed, and wound healing occurred without symptoms. So we have developed actually a working new therapy to help to prevent alveolar ridge resorption. The problem with that product was that it was very hard to convince dentists to use it. Reasons were multiple. For one, it is not so often that an alveolus is really that perfect that you can put in this exact copy. If you have to dissect the tooth in 2 or many pieces to extract it, you cannot make this copy. If you extract wisdom teeth, it's quite hard to insert the root replica back there. You need a machine. You need 5 to 10 minutes to make this copy, so you have to do optimal handling procedure where you work in an aseptic way. So the product did not find the customers, but many of the dentists we approached told us that they liked the idea, they think it's good, they liked the material, they liked what we have shown them with regard to with the results, and they have asked us, can't you put this material in a syringe so we can inject it directly? And that's what we did as a next step. We went back to the lab and worked for an additional 3 years to have an injectable version. And we call this now Easy Graft because it's so easy to use. So it can be applied directly from the syringe into the alveolus, and it will harden in situ. So the trick was that we use exactly the same copied granules, and we add a liquid which we call biolinker. This biolinker is an N-methylpyrrolidone. This is a substance, an organic solvent, which is quite well known, which is used in products like Atrisorb or Atridox. Even the inion membrane uses the same NMP. NMP is used in cleaning agents for spray paints on the walls. That's why it is very, very good documented with regard to its biological behavior. So this is how it works. On the top left you can see the granules with the coating. Here the coating is way thicker presented than it really is. In reality it's just 10 microns. So you add the biolinker to the granules, and biolinker or this NMP will penetrate this coating and make this surface sticky. You press the granules together and form a solid body, and then when it comes in contact with water or blood, this NMP is extracted again from the graft. And so you have more or less a physical method, not a chemical hardening of this bone graft. And as soon as this biolinker is extracted, and we know that 99.5% is extracted within the first 24 hours, you have a solid biomaterial which stays in place. And this is how it is presented. The material comes in a syringe together with an eye drop flask of this biolinker. You just add the content of the eye drop flask to the syringe. You put back the plunger, and your product is already ready to use. You waste the excess fluid of the biolinker into a sterile tissue, and you can inject this material directly into the defect, as you can see in this picture. So it's very easy to apply now a bone graft, and you don't have to handle with these single TCP granules anymore. So once it is in the defect, you can use a stopper to kind of compress the bone graft into the site and to model it as you more or less would do a polymeric filling material. And now you have the advantage that you can really not only fill extraction sites, but you can put it more or less in any bone defect you do have. You can inject it directly from the syringe, mold it, and within 1 minute you have a stable graft there. And the nice thing about this is if the biological environment is good, so you have a coverage with the periodontium, for example, you don't need a membrane anymore. So this saves a lot of time and costs for your clinical practice. You have the clinical benefit of using a phase pure beta tricalcium phosphate, which is infection protected. It's 100% synthetic, and we have proven that it completely resorbs from the body. It's open porous and interconnected. We have worked on that bone graft for over 8 years now to make sure that this is really a product which is safe and works for your clinical practice and your patients. This product is now used in Europe in several indications, including periodontal pockets. It's used for bone augmentation, for peri-implantitis cases, extraction sockets, guided bone regeneration, and sinus lifts. And in the next slides I would like to show you exemplarily one slide of each of these applications. Here you can see a picture where it was used to fill bone defects around implants after re-intervention. So it's very easy to mold it around the implants. It's important to know that the bone graft will not stick or glue to the bone. So it lays there as one solid block and must be covered with soft tissue so that it does not move away in such indications. Here's a picture, an X-ray of a sinus lift that we do. This was done using an internal sinus lift with this bone management balloon lift system. So after the pushing away Schneiderian membrane, the syringes were just inserted directly into the osteotomy hole of the internal lift, and this easy graft was just pushed into the defect. Typically around 1 milliliter of material is used in such defects. Next picture, you can see the use of it in vertical splits. Nice thing is you can really push it into the defect. It will harden and keep the two lamella at the distance you like. Here you see a picture from the extraction side. The material was used also for indications where you have oroantral communications or mouth-antrum connections. You place it in there, let it harden, and so you stop really the communication between the mouth and the sinus. Here I go with you through a small series that was done by Dr. Huber from Erding. He used it in root apectomy. And here you can see very nicely how you can just fill the defect by pushing the material out of the syringe. It almost flows kind of like into the defect. And then you compress the material with a stopper. It hardens right there within about 20 seconds and stays there perfectly. He just now then covers the defect with a suture, and this is it. And next slide, you just see the X-ray controls before and after the therapy. You see this granule structure that you have placed into this site. Now, as last, I would like to go through a perio case. Here we had a patient with a perio pocket of around 8 millimeters, as you can see in the X-ray on the right. It was opened and the standard hygiene therapy was applied, and thereafter this beta TCP composite was injected into the defect and really compressed with a stopper so that it will really fill out the defect completely and stay within the site. Then the wound was closed with a suture without prior use of a membrane. Here you see the bone graft inside. This is the X-ray control after the therapy. After 10 days, the sutures were removed and soft tissue was found to be perfect. There was a normal wound healing. So after 12 months, the patients were controlled, and it was found that the probing depth was in this patient back to 3 millimeters. So we have seen that in all the cases we treated, we really had a much higher bone attachment level as before. Here you see the control of the X-ray after 12 months of this perio patient. All this work is published in various publications, as you can see here. A lot of new studies are going on right now. Here you see the summary of it. We're right now doing 2 internal sinus lift studies. We're doing socket preservation study. We have a study now running on or additional cases of oral-antral communications. There's a perio study running, and now we started the study also on ridge augmentation. Ridge augmentation is an indication that we don't push at the moment, because we first want to learn more about the behavior of this method or of this material in that indication. So in conclusion, we have developed an innovative new type of material that is very easy for you to handle, which helps in your daily routine and can be used in a broad range of indications. We have seen that the dentists in Europe, where it is on the market, really start playing with it, finding new ways of application, and we will be able to present to you over the next months additional cases, studies, to show how the material works optimally within certain indications. One thing that I've learned through my experience in working in the dental field, that it is very expensive to have the right surgical procedure when you use bone grafting materials. If the surgical procedure is right, most bone grafts will work. And I think the future must go into enhancing these synthetic materials even more. Maybe go into the direction of having osteoinductive materials, so that one day we will not have to use any more autologous bone or xenografts or allografts in our work. With that, I would like to thank you very much, and I hope that we will be able to present to you much more results in the future on this new material. Thank you very much.